This will be the first voiceover PowerPoint for the fourth and final exam. Today we'll be talking about the pelvic girdle and hip. The pelvic girdle and hip are important to understand as they are involved with posture, balance, performing of activities of daily living. The pelvis transmits weight up and down the kinetic chain. It's responsible for correct biomechanical locomotion and gait. It's also related and responsible for back pain. The hip joint has two components. The first component pictured here is the innominate. The second component would be the femur, or more specifically, the head of the femur. The innominate and acetabulum, pictured here, is formed embryologically from three separate bones: the ilium, the ischium, and the pubis. The acetabulum is the spot where the femur articulates. The opening in the acetabulum is called the acetabular notch. As we'll soon see, this notch is closed by a ligament called the transverse acetabular ligament. Here we see another picture of the innominate demonstrating its three components. Superiorly we have the ilium, posteriorly we have the ischium, anteriorly we have the pubis. This picture nicely shows how the acetabulum is made up of those three bones. The other component of the hip is the femur. Here is the head of the femur, the neck of the femur, and we have the greater trochanter and the lesser trochanter, which serve as a major site for muscle attachments of the hip. The femur has an indentation in the head. This indentation is called the fovea capitis. The fovea capitis serves as the attachment site for the round ligament of the femur. The round ligament of the femur contains an artery. This is the foveolar artery. The foveolar artery supplies blood to the head of the femur. Disruption to the foveolar artery, or round ligament, can result in necrosis of the femoral head and resultant hip replacement. The hip joint is a synovial joint with associated joint capsule. The hip joint is, of course, a ball and socket joint with 3 degrees of freedom. The joint capsule of the hip has 4 thickenings, which create the ligamentous stability for the hip. The strongest of the ligaments is the iliofemoral ligament. The iliofemoral ligament has 2 components. It has an inferior component and a superior component. Here's the inferior component, here's the superior component, here is also the superior component. Posteriorly, you have an ischiofemoral ligament from the ischium to the femur, and anteriorly you have a pubofemoral ligament from the pubis to the femur. Where these ligaments attach on the greater trochanter, either superiorly or inferiorly, will determine the movements that they restrict. The superior band of the iliofemoral, along with the ischiofemoral ligament, limits a deduction of the hip. The inferior iliofemoral and pubofemoral ligament resist a abduction of the hip. The pubofemoral, superior and inferior iliofemoral, and ischiofemoral also resist extension of the hip. The ligaments of the hip are clinically relevant as people who are paralyzed below the waist can use a swing to or swing through gait with an assistive device such as loft strand crutches in order to be community ambulators. The picture below shows a sagittal section of the hip, much like we had a sagittal section of the glenohumeral joint in the upper extremity unit. Here is the acetabulum. That acetabulum is rimmed by an acetabular labrum. The notch in the acetabulum is connected via the transverse acetabular ligament. This labrum is a fibrocartilage lip, just like in the shoulder, that deepens the cavity of the hip and also provides suction to the head of the femur. Coming from this transverse ligament is the round ligament. The round ligament again contains the foveolar artery. This round ligament attaches to the fovea capitis on the head of the femur and provides blood supply to the head of the femur. Any disruption of that blood supply will cause necrosis and likely necessitate a hip replacement. Surrounding the articulation is the joint capsule. Here we see the pubofemoral ligament, the inferior and superior iliofemoral ligaments, and the ischiofemoral ligaments as thickenings within that joint capsule. The picture you're looking at is a left hip. Here are the posterior muscles. Here are the anterior muscles. Here is the medial muscles or medial compartment. Of course, anteriorly we have the femoral nerve, femoral artery, femoral vein, just to put things into perspective. The hip, much like other joints in the body that we've already discussed, has a number of bursa. The bursa are there to decrease friction. The first bursa is the trochanteric bursa. The trochanteric bursa lies over the greater trochanter and deep to the iliotibial band. Tightness or compression on this trochanteric bursa can cause trochanteric bursitis. Trochanteric bursitis can be brought on by a number of reasons. One of many may include a weak glute medius that causes a deduction of the hip during gait, thus increasing compression on the band. Next is the bursa for the obturator internus, called the internal obturator bursa. That bursa sits right in the lesser sciatic notch between the ischial spine and the ischial tuberosity. The external obturator bursa sits on the neck of the femur. This bursa reduces friction from the tendon of the obturator externus. So how you may be able to remember that is the internal obturator is sciatic. So the I in internal matches the I in lesser sciatic notch. The external obturator bursa sits on the neck of the femur. So external and neck. The E's go together. Next is the gluteofemoral bursa. The gluteofemoral bursa sits between the gluteus maximus and the posterior aspect of the vastus lateralis. Last is the ischial bursa. The ischial bursa lies under the hamstring tendons and superficial to the ischial tuberosity. Clinically, we see ischial bursitis in patients that have above the knee amputations, as the sockets can sit on the ischial tuberosity. So during gait, you get compression of that bursa. We also see it in older folks who have muscle wasting in the posterior muscles, such as the gluteus maximus. So when they are sitting, they have less cushioning between their ischial bursa and whatever they are sitting on. The two bursas that you will likely see most in clinical practice would include the trochanteric bursa or trochanteric bursitis and ischial bursitis. For the exam, you should know if a patient was having pain in any of these areas, what bursas would be involved. Here we see the muscles of the posterior hip. The most superficial of muscles is the gluteus maximus. Superior, lateral, and deep to the gluteus maximus, we have the gluteus medius. So if you palpate your posterior iliac crest and go posterior to that, you will be on the gluteus medius. Over here, we've taken the gluteus maximus off. We have gluteus medius. Deep to gluteus medius is gluteus minimus. So we have gluteus maximus, gluteus medius, and then deep to medius is gluteus minimus. Inferior to gluteus minimus and medius, we have this pear-shaped muscle. There's the pear, there's the stem or the tendon, and that pear-shaped muscle is known as the piriformis. The piriformis is an excellent landmark for both the superior gluteal artery, vein, and nerve. These come out of the pelvis superior to the piriformis. As you recall, the superior gluteal artery comes from the posterior division of the internal iliac artery, and the inferior gluteal artery coming from the anterior division of the internal iliac artery. The inferior gluteal artery runs with the inferior gluteal nerve and vein. As you'll recall, the superior gluteal nerve, artery, and vein go to gluteus medius, gluteus minimus, and the tensor fascia lata. The inferior gluteal artery, vein, and nerve will all go to gluteus maximus. The other landmark that's generally associated with the piriformis is the sciatic nerve. The sciatic nerve generally comes out below the piriformis and courses down the posterior compartment. As you'll recall, the sciatic nerve is made up of two nerves wrapped in a fascial sheath. Those two nerves are the common peroneal nerve and the tibial nerve. In approximately 8 to 20% of the population, that sciatic nerve splits within the pelvis. The common peroneal nerve will pierce through the piriformis, and the tibial nerve will come out below the piriformis in the traditional location that the sciatic nerve exits the pelvis. This can increase the likelihood that your patients will suffer from what is known as sciatica, or pain down the back of the leg. Inferior to the piriformis, we have a group of four muscles. We have a superior gemellus, obturator internus, inferior gemellus, and the quadratus femoris. We'll talk about innervations and actions in the next slide. So here we have that picture of the sagittal section of the hip. And just a reminder to let you know sort of where things are. Here's the section we just got through with. So there is the gluteus maximus, that is most external, gluteus medius, and deep to gluteus medius is gluteus minimus. Here's the piriformis with the associated sciatic nerve. Then we have the tendon of the obturator internus. Superior to that is the superior gemellus. Inferior to that is the inferior gemellus, with the quadratus femoris rounding out the posterior group. Let's talk about individual muscles and their actions. Muscle number 1 is the gluteus maximus, that is innervated by the inferior gluteal nerve, L5-S1-S2. The gluteus maximus is an extender and external rotator of the hip. Number 2 would be gluteus medius. Number 3, gluteus minimus. Gluteus medius and minimus are innervated by the superior gluteal nerve, L4, L5, S1. They are abductors of the hip and internal rotators of the hip. In fact, they are the main internal rotators of the hip. The other job of the gluteus medius and minimus is to keep the hips level during gait and stair ambulation by eccentrically preventing a deduction of the hip and a resultant drop in the pelvis. Number 4 is the piriformis, our pear-shaped muscle that is innervated by the nerve to the piriformis. Its action, much like the supraspinatus, is determined by the position of the hip. The piriformis is an internal rotator with the hip in flexion and an external rotator with the hip in extension. Number 5 is the quadratus femoris. The quadratus femoris is innervated by the nerve to the quadratus femoris. It is an external rotator of the hip. Number 6, those are the superior and inferior gemelli muscles. The superior gemellus is innervated by the nerve to the obturator internus. The inferior gemellus is innervated by the nerve to the quadratus femoris. Both the superior and inferior gemellus are external rotators of the hip. In number 8, we see the tendon and the muscle belly of the obturator internus. Again, the obturator internus sits between the superior and inferior gemellus. The obturator externus is innervated by the obturator nerve, L2, 3, 4. So when we talk about innervation, the innervation to the superior gemellus, obturator internus, inferior gemellus, and quadratus femoris is a shared innervation. So the superior gemellus and obturator internus, the top two muscles, if you will, are innervated by the muscle below, the nerve to the obturator internus. The inferior gemellus and quadratus femoris are innervated by the muscle below, which is the nerve to the nerve to the quadratus femoris. So superior gemellus, obturator internus, nerve to the obturator internus. Inferior gemellus, quadratus femoris, both innervated by the nerve to the quadratus femoris. Also included in the hip is muscle number 9, which is the tensor fascia lata, or TFL. I include the TFL in the muscles of the hip as it is innervated by the superior gluteal nerve. The tensor fascia lata attaches to a fibrous band, which is actually a thickening in a sheath that envelopes the entire thigh. The tensor fascia lata is a hip flexor, abductor, and internal rotator of the hip. It also can facilitate knee extension by its attachment to the iliotibial band. Last, we have the iliac muscles. The iliac muscles may look familiar as we I've previously spoken about them as being muscles that comprise the posterior abdominal wall. The psoas major that attaches from the transverse processes in the lumbar spine combines with the iliacus, which attaches superiorly at the iliac fossa. These combine to form the iliopsoas, which share a common tendon that attaches at the lesser trochanter. The psoas major and iliacus become the iliopsoas distal to the inguinal ligament that attaches from the ASIS to pubic tubercle. The iliopsoas is a major flexor of the hip, especially above 90 degrees. The rectus femoris, one of the quadriceps muscles, is also capable of flexing the hip, although the rectus femoris becomes actively insufficient at about 90 degrees. So the psoas major is a one-joint hip flexor. It is unaffected by the position of the knee, as is the rectus femoris, which is affected by the position of the knee. So the iliopsoas is your major hip flexor above 90 degrees. The last muscle, psoas minor, is a muscle similar to the palmaris longus. Some have it, some don't. It attaches from the upper lumbar spine to the pubic ramus. Pain as a resulting from psoas minor tendinitis has been seen by yours truly in a marathon runner. I've only seen one case. However, if you know the psoas minor may exist in your patient and it attaches to the pubic ramus, your patient is complaining of pain at the pubic ramus that you can either palpate or reproduce, your patient may have a psoas minor tendinitis. The psoas major, psoas minor, and iliacus are all innervated by the femoral nerve. The femoral nerve, which comes from L2, L3, L4, courses inferior, just lateral to the psoas major and just medial to the iliacus. So it certainly makes sense that the femoral nerve would innervate both of those muscles. If the psoas minor is present, it is also innervated by the femoral nerve.